Hey guys, Tony Maritato here. So let's dive into the CMS guidelines on what exactly is required for a progress note. I think you guys are going to be surprised when we're talking about progress notes. Now, this is a segment that I usually cover in a lot more detail in my Learn Medicare Billing course, but I think this is important enough that I want to share it publicly so you guys understand what a progress note is, what a daily treatment note is, how those two interact with each other. So let's jump into CMS Chapter 15, the Medicare Benefit Policy Manual, and we're going to go down into the documentation section. Let me show you what I'm talking about. Here we go with the document. We're going to scroll down to section 220, subsection. Let me see if I can find it here. I keep jumping past it. 220.3, and this is the general guidelines around documentation. Absolutely a must read for anybody who's treating Medicare beneficiaries. But I want to specifically go down to the segment regarding progress notes. This is all about evaluation. In the course, we have checklists to make sure you don't miss any of the required components in the documentation for an evaluation and a plan of care. We also have a checklist for the progress note. So let's take a look at this. The number one kind of misnomer, wives' tale that I see posted a lot is the 30-day requirement for a progress note. Now, that was consistent back in the day when we had the functional reporting. We don't have that since January 1st, 2019. So here you can see that under timing, the minimum progress reporting period shall be at least once every 10 treatment days. So it's not 10 calendar days or business days, it's 10 treatment days, and there is no 30-day requirement. So 10 treatments could span 6 weeks, it could span, I don't know, a week and a half if you're doing every day, right? So the first part is there is no 30-day reporting requirement. It's 10 treatments or sooner. You can do it on the 8th treatment, and then your clock resets. So number 9 is actually number 1 of the next reporting period. I'm going to jump past the examples. Again, this is all stuff that you guys should be familiar with. In terms of absences, there's some great information here related to the patient's absence, delayed reports. You know, something that people always wonder about. You actually have 7 calendar days to get the report finished. I would tell you get it that day. Like that patient who's sitting in front of you on the day of the progress report, they are your lifeline. They are the only thing protecting those minutes for you on getting that report done. As soon as that patient walks out the door, or as soon as you leave that patient's house, I guarantee there's 20 other things sitting on a list waiting for you. All these other fires that you need to put out, if you don't get the report done right then and there, you're going to be miserable. And that's where you hear the stories of clinicians taking home piles of paperwork because they don't do it with the patient. The patient should be intimately involved with a progress report. That is your time to sit there and talk and communicate and see how they're doing. Review the goals. How have they progressed towards certain goals? Have they met goals or have they not met goals? Why have they not met those particular goals? What can you do differently? Do you need to modify those goals? Are they not attainable? In a case like that, you're looking at actually changing the plan of care. But this is your time to connect with your Medicare beneficiary patient. So protect it. Don't just let it go by. Don't just spend it as billable treatment time. You need to get this stuff done. Now, let's jump down. So you have 7 days to get the report done for timely reporting. There's information here you can see regarding early reports, which I already mentioned. You don't have to do it on the 10th session. None of you guys are billing incident to a physician, so I'm just going to skip over that part. Let's jump down here. Now, this is actually kind of interesting. It never clicked for me that technically a discharge note or a discharge summary is a progress report. And you can see here in the guidelines that the physician does not need to sign your progress reports. I always understood the physician didn't need to sign my discharge summary, but it never made sense to me, or it never clicked that the physician doesn't need to sign my progress reports unless you're using that progress report to extend a certification, to recertify a plan of care, change your plan of care. In that case, the physician absolutely has to sign it. But if it's a standard progress report within the certified plan of care, there is no physician signature required. Super interesting to me. You know, it's funny how it isn't until you really dig into the guidelines that you start to realize this stuff. Most of you watching this today are not using PTAs or OTAs, but there is a segment you can see right here on how and what the assistant can do related to the progress report. Let me jump down here a little bit further and let's see what we've got. Okay, so contents. The content of clinician progress reports. There needs to be assessment of improvement, right? The extent of progress or lack thereof to each goal. Probably one of the most important things on your plan of care are your long-term goals. So the progress report is going to summarize progress toward those long-term goals, assuming there is progress. If not, why no progress? Plans for the continuing treatment, reference additional evaluation results if they were done, and or any treatment plan revisions. That's where I was saying you might have to revise your plan of care if you realize that a patient's not going to meet one of your long-term goals. That would be documented. Changes to long and short-term goals, discharge, or an updated plan of care that's sent to the physician for certification. Anytime you're changing the plan of care, it has to be recertified by the physician. So that would be a situation where the progress report is signed by the doctor. Any functional documentation, you know, look at what functional outcome measures you were using. And I'm a huge believer, if you have to use a functional outcome measure that's accepted within your profession. If you're using that, since you're using that, that absolutely should be your long-term goals. Don't try to get creative. Don't reinvent the wheel. Every treatment may be customized to the individual patient you're seeing, but the plan of care and the goals should come straight off your functional outcome measure. Whether you're using photo or optimal or the back index, the neck index, upper extremity, functional score, I don't care what you're using. Take your goals directly from that sheet. And what I try to explain to my members in my zero to paid Medicare billing course is, so you give, or however you do it, the patient the functional outcome measure. You go through, let's take one like a back index. There's 10 questions. They answer a question about lifting. On that question, they indicate the score is a 3, right? So I don't remember what it is off the top of my head, but let's just say they cannot lift heavy loads without pain or because of pain. Prior to the onset of this condition, they were able to lift a heavy load. Now, maybe you take a heavy load and you say, okay, 45 pounds, 145 pounds, you quantify that. But the bottom line is, they indicate on the functional outcome measure they can't lift a heavy load. Prior to onset, they were able to lift the heavy load. My belief as the clinician doing the evaluation is I can get them back to lifting a heavy load. So I've got current level of function, prior level of function, goal level of function. Just take it right off the functional outcome measure. Don't get creative. It's just one of those things where you're opening Pandora's box and there's no reason to. The information is right there. The more creative you get on a plan of care, the more opportunity for denials, rejections, problems down the road. Just stick to basics. So let's see here, functional outcome reporting, a reevaluation. I talked about this in a previous video. A reevaluation is not required before every progress note routinely, but there may be appropriate when assessment suggests changes not anticipated in the original plan of care. Changes not anticipated. It can't be a routine thing, but there are times, right? I'm treating an individual, for a non-operative shoulder pain condition, patient falls, they hurt that same shoulder, I'm probably going to do a reevaluation, right? Absolutely, they have a humeral fracture that they didn't have before. Unexpected outcome, I'm going to do a reevaluation on that individual. But if it's within the scope of what you would expect, it's not a reevaluation. It's just a progress report. Care must be taken to assure the documentation justifies necessity of service. This is where you're supporting medical necessity. Don't try to support medical necessity on the claim. When you submit a claim, the claim indicates that there's already medical necessity. If it wasn't, you wouldn't be submitting the claim. The progress report is where you're justifying medical necessity. So in the case of rehabilitative therapy, patient's condition has the potential to improve or is improving in response to therapy. You want to indicate that maximum improvement is yet to be attained. Guys, keep watching because I'm going to show you their example here in a second. In the case of maintenance therapy, treatment by a therapist is necessary to maintain, prevent, or slow the deterioration. But remember, it's treatment by a therapist. There's a lot that somebody can do that doesn't require the skills of a therapist in a maintenance program that's not billable and open to self-pay. Obviously, we need some objective evidence, standardized patient assessments. So let's take a look at this little blurb right here. This is put out by CMS. And what you see is, so there's some background information around the top. Then we get into, you see a short-term goal here. You see goal number 2 here. But this is the part that I think is most interesting. Let me scroll up so you guys can see it on the screen. The progress report for January 3rd, 2006 to the 29th. Number 1, improve to 80% of trials. Number 2, these are related to goal number 1, goal number 2, achieved. Comments, highly motivated. Spouse assists with practicing compliant with current restrictions. This individual clinician establishes a new goal. Then they sign off on it, right? Mary Johns, SLP, the date. That's it. So this whole section right here is really the meat of the progress report. Note, the provider is billing that code 3 times a week, consistent with the plan. Progress is documented. Skilled treatment is documented. We're not even looking at 1, 2, 3, 4, 5 lines. Like, the progress note isn't a novel. The progress note isn't pages and pages and pages of documentation. This is what Medicare, this is what CMS is telling you and I a progress note should look like. You absolutely can produce more content. You absolutely can write a 3-page progress note. That's well within your, your choice. But that's not what Medicare is paying for. So you're doing it at your own cost, which I do plenty of things that lose me money. I'm not, standing on a high horse saying that I'm better. Like, I make decisions every single day that cost me money because this is what I want to do. But I want you to understand, we see what the progress note is based on Medicare guidelines. You can do more, but just remember, you're paying for it. Your patient's not paying for it. Medicare is not paying for it. Nobody else is paying for it. You are paying for it. So it's your decision. All right, guys, I'm going to wrap this video up. We're already at 14 minutes. In the next video, I'll talk about the difference between a progress note and a treatment note and how those two can be combined. So in many cases, you don't need a separate progress note if you're doing a halfway decent treatment note. Guys, I hope this content's helping you. Please post your questions in the comments on YouTube. Take a minute and hit that subscribe button. We're over 620 as of today. I want to break 700 hopefully within the next month and 1,000 before the end of the year. 1,000 subscribers. That would be huge for us. In the meantime, let me know what kind of questions you have, what you're asking. Guys, I'll catch you on the next video. Thanks as always.